So thanks for having me. I have about 20 minutes to go through kind of an overview of functional restoration. And functional restoration here is going to be talking about more of a model of care, even though all of us today are going to go on and try to improve patients' function in what we do. So we'll talk about what that really means. Just to kind of quickly go through, I run the pain services for Swedish. We're primarily at First Hill. My colleagues include James Babington, who's at Edmonds. We have a clinic at Edmonds and at Issaquah. What I'm going to talk about with the functional restoration program is our site downtown, our main hub. James is, again, joined us from Virginia Mason as a physiatrist and pain management specialist. Wilson Chang joined us from his new house in Bellevue here. He's over there in the back corner. Wilson Chang joined us a couple years ago and is a physiatrist and pain specialist. Chris Merrifield is downtown primarily with us. Fong Xing has also been with us for the last over a year now. Came from Boston from fellowship in his anesthesia pain. And Kong Yu's been with us for a number of years. So that's our physician team. We also have Greg Rudolph, who's an addiction specialist and boarded in pain medicine. Below that are members of our functional restoration program. Sharon Sue, our pain psychologist, joined us. She's in the back as well. When you do a presentation, especially when in front of a bunch of surgeons, you want a psychologist in the back, maybe an attorney, but that's different. Okay, and then our Becca Taylor is our nurse educator. We have an occupational therapist and 2 full-time physical therapists. So that's just a kind of a brief snapshot of our team. I'm going to talk about pain and suffering. I'm going to actually introduce to you, or maybe you've heard this before, update you on some of the new terms and kind of changes in the pain world. I think, unfortunately, when you think about pain, what do we think about? Opioid epidemic, overdose, things like that. That is important, but I think there's also an opportunity to get you guys updated on what's actually happening kind of beyond that, and also how we can treat those types of patients. We'll talk about the HHS Interagency Task Force, which was probably the highest level in the federal government where they actually looked at comprehensive pain management. And a lot of that also includes pain management in the hospital, multimodal treatment, okay? So really trying to do a better job from a disease management of pain. And then we'll talk briefly, we'll go through our functional restoration program, and that's our program that's downtown. First, I think there's really 2 public health challenges, which is important. On one side, we have pictures of unfortunate people that died from drug overdose, whether it be opioids, prescription opioids, fentanyl, heroin. Significant impact, obviously, on society. This is no longer an opioid epidemic. It's a drug abuse epidemic. And we're seeing the increases in methamphetamine, cocaine deaths. We're actually seeing a reduction in prescription-related opioid deaths. Still, there's a lot to be done. But this is really a drug abuse, drug overdose epidemic. And you think about what your patients know now about if you say the word fentanyl. They know more about fentanyl, and they think of fentanyl as obviously the illicit fentanyl that's on the street that people are dying about, even though you guys are going to be using fentanyl throughout the day without even thinking about it, okay? On the other side, we have chronic pain, and HHS and the National Pain Strategy actually a number of years ago pushed for this newer term, which is called high-impact chronic pain. High-impact chronic pain is pain that affects you on most days over the last 6 months. High-impact chronic pain is probably the pain that's going to bring a patient to the clinic or the health community to get treatment. If you look at the numbers, and the surveys came out where they look at like 33,000 people. They do these big national surveys to get better questions about the epidemiology of everything. They've included now more specific questions around pain. 50 million people have chronic pain from those surveys, and high-impact chronic pain is 20 million. So that's 1 in 12 Americans with high-impact chronic pain. And if we looked at opioid use disorder, that's 2 million. And unfortunately, a small percentage of those patients are actually getting the right treatment for opioid use disorder. So if we look at pain briefly, I know I only have a couple of minutes here, what was wrong with the old approach from the 90s and 2000 where there was this huge overprescribing of opioids? The focus was just on opioids. And non-pharmacologic was discussed, but was always given kind of this mention at the end, okay? And so, what's the real future? And the future's actually been around looking at other non-pharmacologic interventions. And that's where I hope we'll be someday. I think at Swedish we're doing that, but really trying to train primary care providers, therapists, and everyone, including the public, what pain should be. So multidisciplinary care includes everything on the right: PT, behavioral medicine, interventional treatments, complementary education, mind, body. And I'll talk about how we integrate those into our pain rehabilitation program. And there's still a place for opioids. Opioids are still the most powerful analgesic we have. And there are some patients that can benefit from that as part of their treatment versus everything being opioids and then work your way backwards from there. If you think about patient-centered pain management, on the right is what we're doing with regards to comprehensive outpatient care. We do interventional procedures, we have pumps, stimulators. There's huge advancement in that area. Medical management, interdisciplinary care, which I'll talk about, complementary, and addiction medicine and behavioral medicine. On the left is actually the hospital side, and how do we kind of bridge that gap? And I always think what we do on Thursdays for the Complex Spine Conference is there. It's how do you bridge taking a patient that gets evaluated for surgery and figure out what they actually need from a multidisciplinary standpoint, but also integrating pain management, better practices in the emergency rooms, primary care. So there's a lot still needs to be done. If we're going to talk about these models, it's important to understand some of the terminology. If you start on the left, parallel practice, and move to the right, you get more integrative and more collaborative. Okay, so parallel practice may be in the emergency room, like you talked about with this patient that's had a spinal cord injury. Very quick treatment, assessment. As you move to the right, though, you may get into multidisciplinary, where a patient is seen in the clinic. They're also referred for physical therapy. That's multidisciplinary. To the right, and even more integrative with less hierarchy and less autonomy of the providers and more team-based care, is interdisciplinary. And the most integrative is probably, the most comprehensive would be an integrative model, which our healthcare system really can't provide that yet. So from a treatment standpoint, we've done a lot around opioids with risk stratifying patients, educating them about safe storage, engaging patients better about their pain. But really, it's how do we look at these models across? And so I think of on the left is more acute pain, which is more a biomedical approach. You fix the disc, you do the discectomy, the nerve recovers over time, they get better. We do a lot of biomedical treatment. It's not a problem. Chronic pain is moving more towards the right, and then even more intense pain, like high-impact chronic pain, you really need a biopsychosocial model. And so we'll talk about the biopsychosocial approach. For the sake of time, I always wanted people to remember about pain. Pain's a threat to the biologic integrity versus suffering is the threat to the person. And Casal talked about this a number of years ago in the medical community. Suffering is the pain changes the intactness of the person. They're no longer the person they used to be, even though we ask them their pain score. And we poo-poo pain scores because, that's not worth it. But the pain score, that 10 out of 10 or the 40 out of 10, the out-of-body pain experience report probably is a suffering score. Again, for the sake of time, I thought this was a really good review that came out from Sean Mackey's group at Stanford, where they actually broke down in a nice review all of the different areas of not the pain matrix. We haven't identified an area of the brain that's responsible for pain, but we have a better understanding of how pain is processed, whether it's the prefrontal cortex, planning and motivation, in the sensory and motor cortex, moving deeper into the subcortical regions for cognitive control of pain, pain unpleasantness. We've been able to identify those areas. And in green is the descending modulation, which is important in opioid modulation, serotonin, norepinephrine. And so those areas have been identified. And so the question is, how do we understand that to better improve how we treat pain? And with that, there's been a lot of work done on looking at structural changes. And the structural changes, I'm sorry, I missed here, is this actually shows changes in mapping in the brain regions, changes in glial activation. A number of different things have been identified now with complex neuroimaging to really show that there is plasticity and there is sensitization and changes in the nervous system. And you guys see that a lot, doing surgery, brain surgery, and understanding plasticity with strokes and things like that. So I'm sorry about the slide here, but again, nice reviews really showing these changes in brain function. It's important because if we don't understand that, how do we explain that to patients? This is actually some new terminology. In the past, we've talked about pain as nociceptive versus neuropathic. Nociceptive pain is pain arises from activation of the nociceptor, so we thought of like inflammatory pain, arthritis. On the other side is neuropathic pain, where there's a change along the nervous system. Nociplastic pain is more what was described previously as maybe sensitization. Nociplastic pain is, there's altered nociception, but there's no actual or threatened tissue damage that can be identified. So fibromyalgia, these other types of pain conditions, central pain conditions, kind of fall under that. So you'll start to hear this newer term, nociplastic pain. Just briefly, the ICD-11 is actually going to be changing in 2012. This has already been approved. Chronic pain in the past does not have its own classification. And so that makes treatment a lot more difficult. And so there's now going to be systematic classification of chronic pain. So it's not going to be post-laminectomy syndrome and those types of terms. It'll be under this chronic pain parent code, and then within that, chronic primary pain, chronic cancer-related pain, chronic post-surgical and post-traumatic pain. And those things may actually help to improve access to care for patients with chronic pain. Again, for the sake of time, I wanted to mention the HHS Interagency Task Force. This report came out earlier last year, and they actually were tasked to look at gaps and inconsistencies across the board, whether it's in acute pain, primary care, in the hospital, education, research, and they put together this report, and they actually broke down 5 important areas: medications, restorative therapies, interventional procedures, behavioral health, and complementary and integrative. And kind of moving away from this kind of stepped approach that we always see. And then across that is looking at stigma, looking at risk assessment, access to care, and education. So the key is that all of these should be considered. Not every patient needs all 5 of those, but they're just as important as the other. Okay, it's not medications first and then go to the next. And if you saw the American College of Rheumatology recommendations just came out for osteoarthritis, they, for the first time, did away with stepped care. And they actually show all of the different multidisciplinary types of treatment together, and then based on patient's need is how you give care. Not fail Tylenol, then try this, then try that. Okay, because we know patients are a lot more complex than that. So all of those, I think, are moving to better understanding and supporting multi- and interdisciplinary care. And this is from the report. The report talked about the biopsychosocial construct and how important that approach needs to be if we're going to improve pain. And on the right, I know it's hard to read, it actually spent a lot of time breaking down the patient-centered approach and what that really means. So maybe one patient needs an NSAIDs and yoga. Another patient needs nerve blocks, short-term cognitive behavioral therapy. So really individualizing patient care based on their needs. And again, they broke down these 5 areas. I'm going to touch upon restorative therapies. Restorative therapies includes physical therapy and more active therapies. And they actually talked in there and made recommendations that there should be multidisciplinary care at the primary care level, not this is a specialty care problem. And payers should reimburse using chronic disease management, just like we treat diabetes and cancer, looking at pain as a disease. And then reimburse care team leaders. CPT code is needed for pain care coordination. A lot of what we do with complex pain management, we don't get any type of reimbursement for. And how important is that? Team conferences, things like that. So I wanted to just go through just a couple of larger studies that came out in the last 2 years. One was from Mayo Clinic and from Cleveland Clinic. They both have interdisciplinary pain programs similar to the Rehab Institute of Washington, 8 hours a day, 4 to 5 weeks, very comprehensive. And they both showed, the Mayo Clinic study, that there was a pre-treatment opioid patients had more interference and more likely to be on polypharmacy, but they actually, whether you're on opioids or not, had the same outcome. It wasn't, oh, if you're on high-dose opioids, you can't do well. And most of these programs wean patients off opioids while they're in the structured program, and I'll talk about our structured program. And Cleveland Clinic showed similar findings, and they actually showed significant improvement in treatment benefits even at 6 and 12 months. So there's always been talk that these programs help when they leave, but do patients retain those? And do they retain what skills they learned in the program? And they actually showed a small reduction in what their treatment benefit was at 6 months and 12 months, but it was still clinically significant. And I always say, for a pain, an analgesic that's out there, lidoderm patch, duloxetine, what's the average pain reduction that makes it a $1 billion drug, that those drugs are? What number from 0 to 10? It's like 1.5 over placebo. Okay, so a lot of what we do in pain, there's really minimal literature supporting what we do with that strong analgesic response, okay? So this came out in 2019, and this is just showing the effectiveness from systematic reviews of functional restoration. Overall effect size was standard, a median difference was 0.83, which is very high for overall effectiveness. The highest was around catastrophizing and quality of life. And so that's what I think we teach patients, decrease catastrophizing and improving their quality of life. And we see that in our own program at Swedish. So with that, I wanted to just touch upon, going back to the brain imaging, there has been changes shown, and this is a study that looked at group cognitive behavioral therapy, like 8 to 9 sessions of group therapy, very low intensity, also, though, was able to show increased gray matter volume. A lot of the literature in brain imaging has shown a reduction in gray matter density with chronic pain conditions, and if you can improve pain and can improve catastrophizing, there can be an increase in gray matter. And the thought is that there's structural changes like dendritic, growing dendritic spines that grow, structural changes as well as cellular changes. And so these studies are actually showing that these treatments aren't just kind of voodoo. And even if you looked at patients that respond to any kind of intervention, this other study looked at chronic low back pain, those patients that showed benefit actually had improvements in certain areas of the brain in gray matter density. In the low back pain case here, it was in the dorsolateral prefrontal cortex. Those increases correlated with pain improvement. Okay, so plasticity is reversible. And actually, this study was from Rehab Institute where I was before I came to Swedish. We looked at 25 patients that underwent our pain rehab program and actually showed an increase in the hippocampus size after treatment. And that has to do with memory and improvements in memory and how they process pain imaging or pain processing. So again, this is showing there's actual structural changes. Plasticity is for real, and it's something we can change. So with that, I wanted to go through a patient, and so we're talking about Sandy here. She presents to our clinic. She's had a lumbar laminectomy. It's now 6 months after her surgery. She's still having severe pain. She's not doing well. She's not able to go to work. And so what are we thinking about with this patient? Stress, physical functioning, social, maladaptive thoughts. And you'll see those patients today, I imagine, coming into clinic. And how are you going to approach that patient? So with her, we did screening, and again, for the sake of time, she had elevated depression, anxiety. PCS is pain catastrophizing scale, which was elevated, and TSK is the Tampa kinesiophobia scale, elevated. Is that a patient you want to take to the emergency room? I mean, to the surgery, to this OR? You might have to, or she's already been there, right? And so are those things keeping her from actually improving in her pain, despite the excellent surgery she had done? And there's no neural compromise anymore on her L5-S1 after her discectomy, right? She's got poor coping, poor limit setting with her family. She's got significant maladaptive pain thoughts and depression and anxiety. Those are probably all predictors of her not doing well after surgery, correct? And she's married. She also reports trauma, sexual abuse from her mother's ex-boyfriend. Okay, so we diagnosed her medically. She saw our psychologist at Swedish. We have comprehensive evaluations. They see Dr. Su or Dr. Bailey, our psychologist, for an hour, and then they see the physicians, myself or Dr. Chang. We medically diagnosed her with an S1 radiculopathy. She also has severe myofascial pain, pelvic floor dysfunction. She's got a hip contracture, psoas trigger points. We pick up on some other things that are going on with her. And she's got anxiety disorder and depressed mood. And she's not sleeping well, okay? Would you want that life? No. And she's on 15 morphine equivalents, which isn't a big deal. But unfortunately, people are like, oh my God, she's on opioids. The opioids are probably the least amount of her problem right now, okay? And what do opioids do besides analgesia? Anxiolysis, rewarding, and it's probably the only thing that she gets that's actually good 3 times a day, okay? Even though she tells us that it drops her pain score from a 7 to a 6.5. And you're like, who the hell would take something 3 times a day that it drops their pain by 0.5 point? There's that reward. There's other kind of non-analgesic effects that a lot of these patients get, separate from an addiction problem. So we recommend the pain program. She was also on Soma. We had her wean that before she started the program. And we told her we were going to decrease her opioids while she was in the program and learning new skills. Not, you're a bad person, go down by 10%. Is that going to work if she has no other skills or anything else to help her? No, okay? So it's a lot easier, harder than it sounds, right? Because a lot of our patients don't think they're ready for it. They don't have the values that support it. They don't believe it's needed. They don't have adequate support. So we have to change as healthcare providers as well. We have to change our perspective on how we talk to patients. And we'll explain that well. And I think what the magic soup in our program for functional restoration is all of us being on the same page and at what the messaging is to our patients about their nervous system, about pain. Okay, so we want to correct the irrational assumptions the patients may have, and again, make the patients more active. Now, as a chronic pain patient that's been in bed or not working, severe pain, unable to do anything, fearful of movement, are they going to be ready to go and start being active? Now, so how do we really break that down first to slowly get them back to being a more active participant? And I think this is always good to mention, these kind of vicious cycles, and we teach, I wanted to include things that we actually teach our patients, and we teach our patients about vicious cycles. On the left, she has pain, but she also has anger and anxiety. She's mad about the surgery because the surgeon promised me I'd be 100% better. which I know they didn't say that. She's got poor mood and depression, and that keeps playing into her pain. On the right, she's got activity avoidance. She's got decreased activity, further avoidance. All that's pain and playing into those maladaptive ideas. And then she sees her, tries to go to the gym, and the gym trainer says, let pain be your guide. If it hurts, don't do it. Okay, so she's getting a lot of wrong messages. So we put in our pain program. Our pain program is 3 days a week. This is an example of a Monday, Wednesday, Friday program. Patients would start at 12 o'clock. They're in groups of 4. Monday and Friday is individual treatment, one-on-one, physical therapy, occupational therapy, psychology, and relaxation training. And then Wednesday, they're in the same sessions, but in the group setting. And we have 2 groups at a time. Physical therapy, and again, I wanted to get through this. All of our patients have had physical therapy, and so we approach it a little differently. We do a lot of neuromobilization, strengthening, very graded aerobic program, but we spend a lot of time on kind of using the PT, but also the deep breathing, the imagery, the other things they're learning from psychology while they're doing their exercises. We do a lot with pain neuroscience education, which has been well studied by Mosley. I was in town a couple of years ago. Lowe, physical therapists have championed this, where you teach patients about their body, you use metaphors, and you teach about plasticity. Shifting away from this is a biomedical problem of your disc versus what happens in pain processing. How does depression and anxiety increase your pain? And so this has been really, I think, helped push the more effectiveness of physical therapy when you're treating patients with chronic pain. So that's really this pain neuroscience education. We also teach about sensory. We teach them about the sensory homunculus and how there's blurring of their sensory resolution, and that's why these pain areas are larger. They need to understand how their brain maps are changed before we can start teaching them imagery and why imagery works. So we're giving them that background information as we teach them to self-manage. This is a sensitization from Adrian Lowe's work, where we teach about the nervous system being hypersensitized or sensitized. So at the bottom is normal pain levels and your thresholds for pain, and at the top is where patients with chronic pain have increased firing levels. And so all these interventions on the right, aerobic exercise, relaxation, diaphragmatic breathing, are all going to help to decrease sensitization. And so that's how we explain what our approach is going to be. Occupational therapy works on posture, positioning. Our occupational therapist also does a lot with Tai Chi, and Tai Chi has also been shown to increase gray matter changes, increase these neurochemicals in our body and endogenous opioids. So she's working on function and really breaking down individually what the patient's doing, but also teaching them Tai Chi. Okay, and for the sake of time, I think we understand the occupational therapist approach, pain psychology, and thank God Sharon's here with me. We work on coping, emotional regulation. This is time-limited psychotherapy. They don't need to be in cognitive behavioral therapy for the rest of their life. We have some patients that need PTSD treatment. They may do that before, but this is time-limited, really giving them better skills. We also include mindfulness-based stress reduction, assertiveness, communication skills. I had a patient yesterday with mastectomy pain. She said, I had an aha moment. And you know when a patient says aha? And this is the same patient that came in when I saw her for an evaluation and said, I know about my pain. I have 4 different areas, and I know what to do. And she didn't know what to do, okay? And what we found out was she had more body image issues about her mastectomy. Her husband hadn't seen her naked in 6 months. And it was all about her body image and how that was affecting her pain, even though she tried everything, acupuncture, mindfulness. And so now incorporating that with our treatment program, she's doing a lot better. Okay, and this is from Sharon Sue. Thank you, Sharon. I'm looking at automatic thoughts, intermediate beliefs, core beliefs. And these are the problems that patients may have with maladaptive ideas. And that's why I think, giving patients books about their pain, giving them education is important. But if they have these maladaptive ideas, you have to get to the bottom of that to help correct that. Because if they can't get past that, it's hard to teach them about their pain and move on. Okay, so, a lot of these are, I'm sure my doctor thinks I'm exaggerating my pain. I thought the doctor was going to fix me. Those kind of maladaptive beliefs at the top, and at the bottom more around depression, I'm worthless, I'm a failure. And so how to identify those are going to be key. Pain catastrophizing is kind of ruminating about pain, the feeling helpless. All of that's going to be the focus of behavioral health, but also our relaxation therapists understanding that, the occupational therapists understanding that, me as the physician understanding that as we're working with the patients. This is from mindfulness, what we work on: body scan meditation, 3-minute breathing meditation, mindful walking, mindful movement. Mindfulness, again, can be used for a lot of conditions, especially for pain. And so we use a lot of cognitive behavioral therapy that kind of binds in with mindfulness. In behavioral activation with our patients, behavioral activation, you want to increase activity, increase participation. A lot of our patients aren't participating in activities. How do we identify what those are? And then how do we help them to be more active? So plan according to a schedule, set in the context of measurable and realistic goals with patients. And how do we incorporate pacing? So that would be the behavioral activation, but our occupational therapist also understands that. And this is relaxation training, diaphragmatic breathing, imagery. We teach them those skills. They practice those skills over the 4 weeks, and then they use those skills at home. How do you incorporate that while you're taking care of your 3 kids? How do you incorporate that while you're at work? How do you incorporate that while you're doing their exercises? So that's why it takes 4 weeks and about 15 hours a week to really help patients change that. Okay, I don't know about you, but it would take me 10 years to change the way I do things, right? And so people get entrenched in how they approach things, and so this is really behavioral retraining. Okay, and then fight or flight, we teach a lot within relaxation about how the nervous system is upregulated. There's overflow of the sympathetics, which no longer is important. We don't need that increased sympathetic drive. And so we teach how to increase parasympathetic tone, quieting down the nervous system. So relaxation training, diaphragmatic breathing, all of those will help decrease the sympathetic tone and increase parasympathetic tone. Okay, I'm talking a mile a minute here trying to get through this. My sympathetic tone's going crazy. If I take a deep breath, I'll feel better. So we explain that to patients, but we also explain to them their autonomic nervous system, how that works, so they can understand it. So the key, again, and I'll finish up, is that all of this really becomes interdisciplinary, is all under one roof, but the next step is transdisciplinary, and that's where our PT understands the role of the occupational therapist, and they're reinforcing what they're learning across those disciplines. Okay, so it's really interdisciplinary and transdisciplinary. So she leaves the program. She's got her home therapy program. She's doing her 3 or 4 exercises twice a day, but she's also doing her Tai Chi in the morning. She has 1 or 2 diaphragmatic breathing and relaxation techniques. She's worked on some of these maladaptive thoughts. She's also done a lot with pain education, and I didn't talk about that, but we have a nurse, Becca Taylor, does a great job of teaching our patients about diet, med side effects, sex and low back pain, all sorts of things to give them better information. So she got that training over the 4 weeks. Medication-wise, we weaned her off for a hydrocodone. She now can take hydrocodone once or twice a week if she gets a flare-up. Okay, she's on duloxetine. She was on 3 different muscle relaxers that weren't really doing anything except making her tired, so we had her stop that. She was taking NSAIDs excessively, which wasn't really doing anything, and we put her on trazodone at night for sleep. So this is kind of a typical kind of medication regimen in a patient that would go through a pain program. So these are just some of the kind of quotes we've had from some patients. This was a patient that stated, PT and OT got to my core problems. Relaxation was fascinating to learn about my body and how to control myself, how to control it myself. Psychology was generous and empowered me to get through this tough transition. Nursing gave great information. So again, it's really about supporting these patients, giving them more skills, and making them more active. And that's what's going to help get these patients back to better function. So just quickly, we are starting, this is kind of unique to Swedish, and I'm proud that Swedish is supporting this. There's a federally qualified health clinic, CHC, up in Edmonds. They got a grant to build a pain program within their primary care clinic. So we will be providing services with evergreen addiction services within a primary care clinic. So we'll be there providing functional restoration and musculoskeletal care within a primary care clinic. And I think that's going to be, really a huge win for Swedish and for really where healthcare is going with, doing a better job at those higher risk patients in providing better comprehensive care. And that's scheduled to open in July of this year. Okay, so I quickly went through the HHS Interagency Task Force, the overdose epidemic we talked about. I went through the functional restoration program and those different disciplines, as well as really remembering that this is a biopsychosocial problem, and that approach needs to be biopsychosocial, again, whether it's acute or chronic pain. We talked about nociplastic pain, that term, high-impact chronic pain, and those terms about interdisciplinary and transdisciplinary. I think that's important when we start really trying to decide what's the right, appropriate kind of model of care that we're going to provide patients. Oh, sorry. Okay, and there's Wilson at 6 in the morning, get interviewed on TV. We'll take any interview, did a good job, about the functional restoration program. We had a joint interview with patients with addiction problems from the Swedish Ballard addiction program, as well as patients from our pain program, and did a great interview for the local networks on pain management. So when mentioning opioid addiction and opioid overdoses, really trying to push this idea of you also have to be talking about treating pain better. because there's so much overlap between those two conditions. So thank you.
May I invite the members of your program to come up here? Wilson?
Yeah, Wilson, Chang, and Sharon Su. So.
Please come on up. And so just want you up here because it's so cool that you came. Just come on over here.
Yeah, sorry I went over.
Accept our thanks for your work. So teamwork is so important. I'll just take the prerogative of 2 quick questions because it's so important. Thank you for coming. Thank you all for coming, and thank you for your work. The first question for me is, again, screening. So a lot of screening tests are now finally implemented in EPIC, so cool. Depression scores and all that. But then there's this new body of, I think we have 3 or 4 screens that we try to go through to identify the mind of the patient. Is that perhaps the wrong score? Should we look at something called grit or resilience of patients to try to see how well somebody's able to cope rather than looking at all the end effects, which you've identified very eloquently in a lecture in terms of depression, dysactivity, etc. So grit, resilience, is there a score? Is that maybe the better way to look at it from a general life handling perspective?
Yeah, I think that's
Can you use the microphone?
I think that's a wonderful question. What we do is we do a comprehensive assessment on how people cope with pain and stress. Usually that shows the things they're doing well as the things they're not doing so well. So things like, I went to water aerobics 3 times a day. I have great support. These are good examples of resiliency and adaptive coping strategies. And things are not going well, like I stay in bed all day, watching YouTube videos, which is very common in our clinic. We don't have scores to capture that. I think that could be a good idea. But what I do in my interview is looking at, kind of the range of skills that people have. And of course, yeah, they could have good skills, and we should reinforce them for that. That's a really valid point.
Yeah.
Yeah, and I would just comment, these are all screening scores, depression, so anxiety, generalized anxiety disorder. I mean, we use, different questionnaires across Swedish for depression and anxiety, which is good. I mean, the opioid risk tool, which is more for predicting aberrant behaviors, the one question on there about history of pre-adolescent sexual abuse, many times that's the first time anyone's ever been asked that question. So I think the screening tools are as good as they are. They're tools, but then you have to take a deeper dive. But I do think those tools are underutilized. So the question is using them, understanding, is the patient being accurate? We have some patients that underreport in these kind of questionnaires. So I think it's just more of a screen tool, and then we're fortunate to have a psychologist that takes the deeper dive and can maybe understand, do those screening tools really mean something?
Yeah, and then I'd just like to add, in our initial evaluation, we actually kind of break it down into a medical evaluation done by either myself or Steve, and then there's a psychological evaluation done by either Sharon or Rob. So they spend almost 2 hours with us that first time they step into our clinic. So, we make sure that they're tucked in really well, their compliance, where they at within terms of their care and what they want out of their care. So we have a very nice communication, and we set expectations, short-term goals and long-term goals. That really kind of sets the tone for what they can expect out of our program versus, just getting another pill or an injection and then just getting them shoot out the door.
Yeah, and I'll just comment, I think what Wilson said too, we see a lot of patients, almost like that Parsonage-Turner case. They have this diagnosis of low back pain and whatever that condition was, but they really have other myofascial pain, hip pathology, things that have been missed because everyone got stuck on their original diagnosis. So that's why it's important for us to do a 1-hour medical eval too, to try to figure out what else is happening. Because maybe this patient needs an epidural or needs just medications or the right type of physical therapy. So not every patient referred for functional restoration needs that whole program. I think it's trying to figure out sometimes some more individualized things that may help them that may have been missed earlier.
Can you comment?
I just want to, sorry, go ahead.
I was just wondering about the funding and getting authorization for the program and all that kind of stuff.
So that's always comes up, and that's a good question, DR. So we bill separately for PT/OT services all across the board. I mean, it varies, and thank God for Swedish, we can take Medicare and Medicaid patients at a significant loss to the institution, but we take those patients, and Medicaid has actually improved some of the behavioral health that they'll cover. Many of our patients with commercial insurance have to pay multiple co-pays, like $200, $300 a day just in copay. So the infrastructure in the healthcare system does not support this, and that's where the big change needs to be. Workers' comp's a different story because they're covered automatically. The movement has been to get like a day rate, which we're kind of talking about, where we can go to payers and say, this is what we want to charge for the day to cover those services. But financially, we do a lot of groups, which actually our overhead's small compared to the other things we do in our pain clinic. Financially, our pain program actually does pretty well compared to our interventional procedures and things, which has been interesting. Well, we've just been kind of going through some of our finances. But that's the key. The coverage has been an issue. If they can improve the ICD-11 codes, that may help because a lot of patients don't have coverage. If you mention chronic pain or you mention depression, I mean, it's all over the place. So that's still an issue. But we've been able to do the program. We actually show the Medicaid providers how much our cost is per patient, separate from the poor reimbursement we get. So yeah, you can get reimbursed for something, but if you get 10 cents on the dollar, that doesn't matter. So we actually show them what our cost is to provide the care. And we're hoping over time that's going to change. But the payers have been very slow. They'll talk about naloxone and opioids, but they won't really push coverage. And we're hoping that's going to change.
Steve and Wilson, I just want to congratulate you guys because I think, we're in such a complex healthcare environment right now that you really, the value that you guys add to a service like ours is really immeasurable. And I think what I really like about it, I've sent a lot of patients over, is that you don't focus in on, because a lot of pain clinics go, oh, you're a chronic pain patient, we're just going to manage your narcotics. You actually spend the time to go through all these things, and the narcotics doesn't become the focal issue. And then what I've seen is over time, that gets addressed when you kind of go through all this other stuff. And I think that's really, even the name functional restoration, I really like the way you guys kind of approach it and sit down in the first couple hours and actually talk to them, rather than the focus being on, okay, you're on this many doses of narcotics. I think that's really helpful from my perspective.
Just like a comment. So the design of the program is not intended to get people off of opioids, but when these patients kind of, who've been through multiple services and, seen a lot of specialists kind of go through the program and experience our program, I'm actually surprised almost on a daily basis how often these guys want to stop being so dependent on medications. And, I'd be very, bold to say that these people want to come off the medications volitionally, but we've had many conversations where these guys just want to be more incentivized, have more tools around them, and kind of realize, hey, look, you don't really always have to take pills 6 times a day to feel average, and then they kind of get like a little light bulb goes on, and it's really rewarding.
No, thanks, Rod, for that comment. And the other part, too, is we also convert patients to buprenorphine and take them off, and it really just has to be in a slow, kind of judicious way. I think the patients have such stigma about, oh my God, I'm on pain meds, or this has been a failure. And again, if you don't address these other things and get that right rapport, they're going to be a buprenorphine failure, too. So it's, really how do you space it at the right time? But thanks for your comment. So.
Angela.
Oh, yeah. So the follow-up is they do the program for 4 weeks, and then 4 weeks later they come back on a Friday, and they see the entire team in 30-minute intervals to check in with them, and then they continue to work with the physician. We also have maintenance classes. Sharon does those. All of our therapists have maintenance classes every quarter, every month, where patients can come in, and that's where we can keep people engaged that graduated from the program. And I'm always amazed. I think our patients get more out of the maintenance programs because they go back to a place that helped them. It's a very therapeutic place. They like that. They actually meet other people that they become really good friends with while they're in the treatment program. And so it's kind of like their happy place without sounding cheesy. But then we can keep them engaged. They come back for group PT. They come back from group psychology. We may be seeing them every 3 to 6 months for medication refills. But again, we always tell them part 1 is the program, part 2 is the 4 weeks on your own, and then part 3 we continue to work with you. But thanks for asking.
This is very pertinent to my next question also, so thanks for asking that, but I'll take a different slant. So I became a believer in a integrated pain model from the UW days, from Dr. John Bonica's phenomenal structured pain program. And what they did there was an inpatient 3-week program, which became unaffordable, but as a surgeon, I was amazed what happened there. So I have no doubt, and this is the most constructive approach I've ever seen since then, that these patients, unfortunately, really need to be rewired. It's a very brutal thing. So along those lines, one of the big things that I think has just been missed is reprogramming, rewiring patients. How do you handle the sometimes just horrible home situations that these patients are in terms of trying to get them out of this swamp, this whatever horror, psychologically, physically, financially that they're in? Because this is, again, one of those kind of disease-making phenomena.
Well, I think you bring up a good point. A lot of our patients go back, or they're already in very dysfunctional relationships. They have significant stress at home. So I think first, as we teach them, identifying that first, and then, well, these are going to be your tools to do this. So that's why it takes 4 weeks. And when a lot of times at 4 weeks, we're just scratching the surface of trying to understand that. How do you set limits with your family members? What's your exercise program going to be? Can you get out of your house twice a week to go to the gym? You know, we have a patient in the program now. She's got 2 gym memberships. We were laughing yesterday, and she uses 0 of them. You know, and so a lot of these people have some ways in the community to get out of their house, get out of that. So the psychosocial issues are very important, and that's why, you know, working with the psychologist, some patients already may be hooked in with Sound Mental Health or other groups, but they're not really compliant with the exercise part. So we really have to just look at patients individually. But, you know, I think first of all, many times they've never understood that, and it's just been an opioid issue. But if we help them understand that depression and anxiety makes their pain worse, or stress makes it worse at home, yeah, their stress isn't going to go away. But if they have tools to manage it better, then maybe we're helping them. You know, so. But you bring up a good point. And those same patients are the patients that are high risk for opioid overdose. You know, psychiatric conditions, poor psychosocial support.
This is actually not a question. I just want to reinforce what you said, though, about the follow-up. Dean Ornish, after he proved the diet was important for cardiovascular, wrote a wonderful book a decade ago, Love and Survival.
Okay.
Getting together in the group, that's the happy place. So much of pain management has been functional restoration, but don't tell me about your pain.
Yeah.
I just want to see what you do. And it can be a distant, tough love relationship. And I think you guys do it differently, and I think it's huge.
No, thank you.
Great comment. We could do this probably all day long. This is so important. You see the enthusiasm and the appreciation of the group, I hope. So thanks for coming. And again, I hope that we find many ways to kind of tackle individual as well as big topics together.
Thanks for the referrals. You guys are one of our biggest referrals. So we appreciate that. So,